Hi, my name's Melanie Rosenberg, and I will be a senior at Solon High School in the fall. This summer is my second summer in the Science Internship Program for Nursing. This is my first year as a peer mentor at Hillcrest Hospital. The title of my project is Staff Perceptions of Decision-Making in a Shared Governance Culture. So, what is shared governance? Shared governance is an organizational structure that allows maximal input in decision-making. It can be comprised of unit and hospital-wide councils. Shared governance empowers nurses so that they can operate skillfully, improve patient care and safety, examine nursing practice issues, and exercise the power of decision-making in a collaborative effort with management. How do you measure shared governance? We use the Index of Professional Nursing Governance, the IPNG, which was first developed and validated by Dr. Robert Hess to measure the different dimensions of shared governance structure and process. The tool has 6 subscales. They measure personnel, information, resources, participation, practice, and goals. This study aims to evaluate how nursing management and nursing staff perceive staff involvement in decision-making. It also aims to evaluate the correlation between the participation and resources subscale composite scores. I believe that nursing management will perceive staff involvement as higher than nursing staff themselves. Also, I believe that there will be a strong correlation between the resources and participation subscales composite scores. This sample for the study included all registered nurses, licensed practical nurses, nursing assistants, and nurse techs working at Hillcrest Hospital that are a designated member of one of the 5 hospital-wide nursing councils. It also included all nurse managers and assistant nurse managers. Methodology. Participants were surveyed using the 88-item Index of Professional Nursing Governance, the IPNG, to rate the perceived level of influence, authority, or control subjects had on a scale of 1 to 5. 1 represents nursing management and administration only. 2 represents primarily nursing management and administration with some staff input. 3 represents equally shared by staff nurses and nursing management. 4 represents primarily staff nurses with some nursing management and administration. 5 represents staff nurses only. This shows the timeline of what we did for our study. On June 20th, we sent an email to participants asking them to participate in the study. On June 21st, we distributed the studies to participants' mailboxes and distributed an envelope for return in an easily accessible place. On June 21st through July 5th, participants were given 2 weeks to complete the surveys and return them to the designated envelope. An Excel database was first developed from all the returned surveys. The database was then transferred into an SPSS database for cross-tabulation and analysis of results in aggregate. Subscales 3, resources, and 4, participation, were analyzed using composite scores and median scores. There was minimal missing data, and it was not analyzed. This chart represents how many surveys we had returned and sent. For nurse managers, we sent out 21 surveys. We only got 9 returned with a return rate of 43%. For assistant nurse managers, we sent out 35 surveys and got 11 back. This was a 31% return rate. For nursing staff, we sent out 111 surveys, received 25 back with a 23% return rate. Overall, we sent out 167 surveys, 47 were returned with a 28% return rate. These charts show some demographic data of our population. Most of our population were women, and most of them were RNs. Many of our nurses had worked in nursing for 21 to 30 years. Also, most of our nurses were between the age of 41 and 50 years old. This chart represents whether participants were on a council or not. Most of our members were on both a unit and hospital-wide council. The next 2 charts represent the distribution of composite scores. As you can see, there was an abnormal distribution for composite scores. A Spearman non-parametric correlation analysis was performed to test if there was a significant correlation between the participation and resource subscales. Spearman non-parametric was used because there wasn't a normal distribution, as you could see on the previous slides. Correlation showed 0.283, meaning it wasn't a very strong significance. The next two charts, again, show different subscales. This one is resource subscales, and it shows the composite scores for each question. As you can see, staff perceive their involvement as higher than management for the resources. For the participation subscale, it was a bit of a combination between management and staff, but overall management perceived their involvement as higher. This chart shows the median scores for management and resources subscale. As you can see, no one answered 1.0 with an ideal score of 3.0. If you look at the 3.0 column, 6 people matched the ideal score for management in the resources subscale. For the participation subscale with an ideal score of 4.0, no one matched the ideal score. For staff in the resources subscale with an ideal score of 3.0, 4 participants matched this ideal score. For the participation subscale, again with an ideal score of 4.0, no one matched the ideal score. Once again, the correlation between the subscales was not significant at 0.05. This may be due to the small sample size and due to the fact that only 2 subscales were analyzed. For the resources subscale, staff perceived their involvement in decision-making as higher than management perceived. For the participation subscale, management perceived staff as having higher involvement in decision-making than staff perceived. Median scores show that for the resources subscale, management matched the ideal score 6 times, whereas the staff only matched the ideal 4 times. For the participation subscale, though, neither management nor staff matched the ideal score for shared governance. The findings suggest that shared governance process is still in its early stages of evolution. This study had a couple limitations to it. It's hard to measure the total level of shared governance when only analyzing a snapshot of the data. The perceived level of involvement may have been skewed due to the uneven number of participants in the management and staff groups. If this study were to be replicated again, I recommend it be replicated with a larger sample size by inviting nursing staff from the entire hospital to participate in the study. I also recommend that we compare the results of different departments and specialties. We should also analyze all subscales by using cross-tabulation to see if there are correlations. We should share the findings with all nursing council members, nurse managers, and assistant managers so that they can make the appropriate changes. We should repeat this study once a year to measure shared governance's evolution at Hillcrest Hospital. We should also replicate this study system-wide so that we can get a wide result. Lastly, we should compare medians over time to see if there's a progress toward the ideal outcomes of a 3.0 for resources and a 4.0 for participation. I'd like to give a special thanks to Molly Loney, who was my mentor for research. She really helped me a lot this summer, and I learned a lot from her. Dr. Mary Beth Zaney, who was my nurse researcher, again, she helped me a lot with the analysis and the cross-tabulations for my project. Chris Hunia and Katrina Rodriguez, who were my mentors in Diagnostic Procedure Center and Cath Lab, Hillcrest Hospital for all their love and support, the Office of Civic Education Initiatives, Nedra Starling, and Rosalind Strickland for giving me this amazing opportunity. Thank you.